So I'm going to be brief because I want to reserve most of the time for Tim and for the question and answer. Tim Jost is an Emeritus Professor of Law at Washington Lee University Law School. And many of you probably know him, and if you don't and you're interested in health policy and health reform, you should get to know him as the man who writes an extraordinary blog for the journal Health Affairs. I've known Tim for a couple of decades now, I think. His casebook and health law is really a standard in the field. When I first started reading his work, it was a lot on, I think most of what I actually understand about the Joint Commission on Hospital Accreditation, I understand because of reading Tim's work.
You're dating both of us.
I know. He's written quite a bit on administrative law and the regulation of quality in the healthcare system. He's written about health reform. I think every time that health reform comes up, and so I've written and read many of his books and articles over the years. One of the things that you should understand about Tim, because he understands administrative law so well and understands public administration, one of the things that is really remarkable about him, and I'm sure it will come out in both his presentation and the discussion, is he has a capacity for understanding the details not only of legislation but regulation. He is intimately familiar with the Federal Register, and for those of you who haven't had the pleasure of wading through the Federal Register, you may not fully appreciate that, but take a look and you will. And not only understanding the details of these things, but being able to put them in a broad context of their meaning, the historical evolution of regulation, and what's particularly impressive. I have been spending the last couple of years looking at efforts by presidents to implement health reform using various executive powers, including waivers and executive orders and other things. We started out looking at efforts by President Obama to implement the ACA, and we're now looking carefully at efforts by the Trump administration to, if not repeal, scale back the ACA in different ways. And I have become heavily reliant on Tim Jost's capacity to read very complex legislation, very complex regulations, and somehow in less than 24 hours distill them into English and publish and write about them in ways that make them understandable and accessible to an incredibly broad audience. So, having said that, thank you for everything you've done for me personally, and thanks for being here today. It's a privilege.
Thank you very much,
for that kind introduction. Thank you for inviting me to join you here today. I have long respected the work of the Hastings Center and its stellar work in bioethics. I must begin, however, with a clear disclaimer that I am not a bioethicist. Some of my best friends are bioethicists. At an earlier stage in my career, I taught health law covering some bioethics topics, but I'm not a bioethicist or even an ethicist. I'm rather, at this stage in my career, a lawyer, a journalist, and a consumer advocate. The past 8 years, and in particular since I retired from teaching at the end of 2014, have been primarily focused on 4 projects. One of those Michael just described, which is filing almost daily posts at Health Affairs on developments affecting healthcare reform. Secondly, I have for the past 7 years been a consumer representative to the National Association of Insurance Commissioners, being present on their calls and at their meetings and commenting on their various regulatory issuances and speaking up for health insurance consumers. Third, I talk to reporters several times virtually every day. And I have really enjoyed continuing to function as an educator since I retired from teaching, but now working with a very highly motivated and well-informed group of students, which are reporters. Finally, I am actively engaged with a wide range of healthcare advocates trying to move forward healthcare reform in the United States, or at least to keep it from moving too far backward. It's from my practical engagement as a reporter and advocate that I observe healthcare reform. I rarely focus on the deeper values involved, which the Hastings Center is engaged. Although I intend to talk today about the ethical values governing healthcare reform efforts, I regret that I am neither able to cite from the literature on these issues nor the thinkers who are contributing to that literature, but I would assume that in the discussion that follows, perhaps some of you could contribute that to this discussion. The topic listed in the program for today is healthcare reform. What if we woke up and the Republicans and Democrats were willing to work together? I will address that question before the end of my talk today, but before we can think about common ground, I think we need to understand what divides the Democrats and Republicans, so I will start there. We have just completed an exhausting 9-month debate on the future of the Affordable Care Act. I see this debate as having ended at a draw. After months of repeal efforts, the Republicans failed in the House. Well, they did succeed in the House of barely passing a bill in early May with a slim 217 to 213 vote margin, which would have significantly amended the Affordable Care Act. Republicans in the Senate tried unsuccessfully throughout the summer to arrive at amendments to the House bill that could attract 50 of their 52 votes. But in the end, the clock ran out on their opportunity to enact amendments to the Affordable Care Act without the cooperation of Democrats through a Budget Reconciliation Act procedure. With this legislative failure, I see us at a stalemate. The Affordable Care Act remains in place as the law of the land, but on the other hand, the Trump administration seems committed to do its best to condemning the ACA to malign neglect at best, and at worst to actively undermining it at every opportunity. And the executive order that was released about an hour and a half or 2 hours ago is another step in that process, and we could talk about that in the discussion if people want to. The ACA and most implementing regulations and guidance remain in place, but the ACA will not operate on autopilot. It needs the active support and guidance of an administration committed to making it work with continued tinkering and adjustment, and I assume that's what your work is about on this project. The Trump administration's decision to cut the 2018 open enrollment period in half compared to 2017, cut advertising by 90%, cut support for the Navigator program by 40%, close down the federal marketplaces for maintenance several hours each week during open enrollment, bar regional office staff from cooperating enrollment efforts, and now putting out an executive order to take several steps to open up enrollment in non-ACA compliant products. I think will very likely have a serious effect on enrollment in the Affordable Care Act compliant coverage for 2018. HHS recently released a lengthy draft strategic plan for 2018 to 2022, and nowhere, as far as I can tell, does it mention supporting implementation of the Affordable Care Act. We may therefore be in a situation where the ACA cannot be repealed, but can be left, so to speak, to wither on the vine. The battle over the ACA has widely been understood in political terms. Republicans have tried to pass legislation to repeal it or at least amend it. Democrats have remarkably, given the range of political opinion that they represent, unanimously held the line in opposition to repeal. But the Republicans have ultimately failed, not just because of uniform Democratic opposition, but primarily because of the range of political positions within the Republican Party in the Senate, and indeed in the House, from doctrinaire libertarians to practical moderates, which has prevented them from reaching a legislative consensus. The media have by and large reported the ACA repeal efforts in terms of political alignments. It is customary to understand legislatures as battlegrounds in which stakeholders fight to promote their agendas. Environmental legislation, for example, can be understood as a battle between big fossil fuel and powerful environmental lobbyists. Health reform is peculiar if considered in these terms. Virtually every stakeholder organization lined up against every repeal proposal. The AMA, for decades the enemy of health reform, was right at the barricades the whole time, as were most other physician groups. The hospitals, which probably had the most to lose from the Medicaid cuts, were usually among the first to express opposition. The insurers often held back for fear of alienating members of Congress at a time when they need their support, but in the end they usually weighed in opposition to repeal efforts as well. State governors, insurance regulators, and Medicaid directors were to some extent divided, but opposition to Republican proposals by state officials was usually bipartisan, with moderate Republican state officials such as John Kasich lining up with Democrats in opposition. Reliable Republican allies in most efforts, such as the NFIB or Chamber of Commerce, were largely silent, if not quietly opposed to change efforts. Finally, consumer and disease groups, even some that usually attempt to remain nonpartisan, uniformly and vociferously opposed Republican proposals. Support for Republican proposals seemed to come politically primarily from three corners. First, and arguably most important, a number of big Republican donors are passionately committed to ACA repeal. Late in the game, there was increasing reporting that these donors, who provide much of the funding for Republican campaigns, were very unhappy that the Republicans could not repeal the ACA. This opposition was largely driven by ideology, but also by self-interest. The ACA was one of the few pieces of legislation in recent memory to impose significant tax increases on the wealthy and resulted in a meaningful transfer of resources from the richest to the poorest members of the United States society. The second group to support repeal was the Republican base. Although the American public as a whole opposed repeal pretty dramatically during most of the debate, the ACA rarely popular became more so as the debate went on. The Republican base consistently supported repeal, sometimes by substantial margins. Most congressional Republicans are in safe House districts and are more concerned with a primary challenge from the right than with a tight general election battle, and therefore they were worried about the opinions of their base. Finally, repeal efforts were supported by right-wing advocacy organizations such as Heritage or Cato and fringe physician organizations in the right-wing media. Conservative commentators were divided, however, with some concern that repeal efforts did not go far enough, while others thought, such as Avik Roy or Joe Antos, thought that the repeal proposals were poorly thought out. And some conservative commentators participated in bipartisan task forces with progressive analysts sometimes reaching common ground for moving forward. Stirring beneath the surface tumult were discernible differences in values. One major value divide is differing concepts of justice and fairness. Deborah Stone articulated this division about a quarter of a century ago in an article published in the journal Health Politics, Policy, and Law, entitled The Struggle for the Soul of Health Insurance. On the one hand, she wrote, is the principle of solidarity. The solidarity principle is based on the belief that we are all in this together. We share a common humanity and are obliged to care for each other. We are all exposed to the vicissitudes of life. If you need my help now, I will likely need your help later. We should, therefore, all contribute to the common good. The solidarity principle supports widespread redistribution of resources from the wealthy to the poor and from the healthy to the sick or injured through government programs. It underlies most European healthcare systems and our own social insurance programs, Social Security and Medicare. It motivated efforts to bring universal coverage to the United States throughout the 20th century and finds current expression in single-payer proposals. The principle of actuarial fairness, on the other hand, proposes that each individual should only bear the cost of his or her own actuarial risk. Stone describes it as, and I quote, an anti-redistributive ideology and a method of organizing mutual aid by fragmenting communities into ever smaller, more homogeneous groups, leading ultimately to the destruction of mutual aid. She said, this fragmentation is accomplished by fostering in people a sense of their differences and their responsibilities for themselves, rather than their commonalities and their interdependence. Although in its earliest stages, health insurance in the United States in the 1930s was offered without medical underwriting, once some commercial plans began to offer coverage on an underwritten or experience-rated basis, it became a business necessity for all to do so. It took the heroic measures of the Affordable Care Act to end health status underwriting. The ACA not only included a ban on health status underwriting explicitly and pre-existing conditions exclusions, but also included requirements for guaranteed issue and renewal in the individual and small group markets. It included community rating, a single risk pool requirement, a defined essential health benefits package, a prohibition on discriminatory marketing and benefit packages, and a risk adjustment program to ensure that if insurers ended up with a healthier than average group, they would then share the cost of insuring the less healthy with insurers who ended up with those people. All of these measures together were needed to eliminate health status underwriting and exclusion of people in conditions that were pre-existing. It is my understanding that most insurers are not eager to return to health status underwriting, although some persist in selling fringe underwritten products, and that may become more common after today's executive order. But the rhetoric of actuarial fairness continued in reform efforts. One example was the debate over the ACA's essential health benefits. A frequent complaint was, why should I have to pay for your maternity benefits when I'm a guy or when I'm above childbearing age? There are a number of responses to this. Weren't you the beneficiary of maternity services at some earlier point in your life? Do men have any role in women needing maternity services? Or why should I pay for your prostate cancer treatment? But the basic question is, why should we all share the health care costs that high-cost people incur? Or should we find ways to carve up benefit packages and design underwriting so that ever smaller homogeneous groups receive benefits and pay premiums based on their needs and usage? A major, perhaps the most important value in conservative visions of health policy is the idea of personal responsibility. There are several manifestations of this value. The first underlies differing understandings of disease and injury. Are diseases and injuries primarily the result of personal choices, sins, if you will, or are ill health and injury more or less a matter of random chance? If people are responsible for their own ill health and injury, the argument is stronger that they should bear the costs of those illnesses and injuries. On the other hand, if illness and injury are randomly distributed, the argument is stronger that their costs should be shared. The argument is I don't smoke, I exercise every day, I eat healthy foods. Why should I have to pay for the health care of people who are sitting around all day watching television, eating junk food, and chain smoking? Some diseases and injuries are certainly related to personal behavior. Obvious problems are smoking, drinking too much alcohol, eating the wrong foods, not exercising, texting while driving, or having guns around the house, although we can't research the last one. But progressives would argue much of disease is determined by genetics or by environment or by lack of access to health care, preventative or curative, or simply by the wearing out of the human body. And causes interact. The same diet may cause different levels of weight gain in individuals with different genetic predispositions. Lack of access to health care might cause conditions attributable in part to behavior to become much more intractable. Finally, one can argue about whether behaviors are in fact wholly volitional and whether individuals can be held responsible for them. Some substances like tobacco and narcotics are physically addicting, but other kinds of products or behaviors but emotional causes of damaging behaviors can also be intractable. A belief in personal responsibility also contributes to opposition to Medicaid and other benefit programs, at least for those who don't qualify as the worthy poor. Atul Gawande described this in an article on healthcare rights in the New Yorker last month. Many Americans believe that federal programs cause dependency, and those who take advantage of them are lazy shirkers. Perhaps they believe that there is a role for Medicaid for the totally disabled, but able-bodied people ought to take care of themselves, and this debate showed up a lot over the summer. As reforms that have brought less healthy people into the individual market have driven up premiums, those with income slightly too high to qualify for assistance have come to further resent those who are getting help, and individuals with very high deductible policies resent people on Medicaid who get coverage without cost sharing. Gawande and others have described the deep resentment of those who have tried hard to pay for their own health and feel others get health care and feel others are getting it for free. The belief in personal responsibility also leads to a belief that individuals should pay more of the cost of their own health care. Advocates of consumer-driven health care have played a major role in Republican health care circles and have leadership roles in the current administration. The basic idea of consumer-driven health care is that health insurance should take the form of high deductible policies and that routine and less expensive health care should be covered out of pocket. The government should offer tax subsidies for health savings account that will allow individuals to cover routine care out of their own savings or forego that care and keep the savings. Advocates believe that people are empowered by high deductibles and health savings accounts, and that when they are empowered, they will consume only the care they need, reducing the consumption of wasteful services, and they will shop around for the best deals, bringing down the cost of care generally through competition. Even the poorest individuals should have to pay something for their health care, and power accounts coupled with Medicaid will empower all consumers, including the poorest among us. Consumer-driven health care will reduce cost and reduce consumption of wasteful and inappropriate care and improve the quality of care. We have known since the Rand health insurance experiment 40 years ago that in fact increasing cost sharing reduces healthcare spending. Indeed, much of the historic decline in the growth of healthcare costs over the last decade has been due to the increase in cost sharing for consumers. It's less clear, however, whether this reduction in cost is an unmitigated good. Most of the cost reduction is attributable to the reduction in the use of services rather than in the reduction in the price of services. In fact, price comparison shopping is still not an option for most services in most places and may never be a realistic option for some services like emergency care. Instead, increased cost sharing primarily reduces the cost of care by incentivizing people to use less. This could mean waiting to see a primary care physician rather than going to the emergency room or not going to the doctor at all for flu or cold. But it could also mean skipping prescriptions for maintenance drugs or pill splitting or not seeing a doctor when care is really needed. The most important decisions amenable to the influence of cost sharing is whether to initiate contact with the healthcare system at all, and in particular when we're talking about hospital care. Once you're admitted to a hospital, you pretty much lose control over what they're going to do to you. As we all know, the vast majority of healthcare costs are attributable to a very small part of the population in any given year, and much of this cost is attributable to care received in cost ranges well beyond any out-of-pocket limits. Increased cost sharing is a particular problem for the very poor, for whom even very small co-payments can deter access to care. Attempts to incorporate consumer-directed principles into Medicaid have also proved confusing. Indiana's Medicaid program has been held up as an example of using consumer-driven care for Medicaid, and enrollees there do have these power accounts, which are similar to healthcare sharing accounts, savings accounts. But a survey of Indiana Medicaid beneficiaries found that over half of those with power accounts either did not know what a power account was or didn't know that they had one. The consumer-driven health care controversy is the manifestation of the tension between those who value most efficiency and those who put more weight on equity in healthcare, another classic values divide. Efficiency here could be understood in the common sense of reducing the costs of production and delivery, or in the more technical economic sense of the optimal allocation of resources so that no one's situation can be improved without someone being hurt. A primary argument for consumer-driven care is that it does increase efficiency because consumers only purchase care that they value themselves, that increase their own welfare, and that increase their own welfare more than alternative goods and services would. Those who would limit cost sharing contend that it is inequitable, as I've already said, because it increases cost sharing, because increases in cost sharing disproportionately affect those who can't afford care, like Medicaid recipients. Efficiency and equity, however, are not necessarily in opposition. Cost sharing can be graduated based on income, and value-based purchasing can ensure that high-value services are available to all. But advocates of consumer-driven care often seem to me to downplay the issue of affordability. Beliefs in the superiority of markets and in the inevitable inferiority of government-directed programs are also driven by concerns for efficiency. These beliefs underlie attempts to turn Medicare into a voucher system, to use managed care organizations to provide Medicaid services, or indeed the ACA's marketplaces. The ACA was largely based on principles of markets. They also appear in every story that conservatives tell about the failures of single-payer systems. Single-payer advocates, of course, believe that markets prevent the equitable distribution of services, but that they are in fact wasteful and prevent efficiency as well. Values conflicts also play a role in debates about federalism. Conservatives tend to argue that authority over healthcare programs should reside at the state level. The argument for state control is that healthcare costs and needs vary from state to state, and that also values vary from state to state. Liberals, on the other hand, argue that disease and injury are the same everywhere, as is poverty, and that every U.S. citizen or resident should be entitled to the same care. Moreover, only the federal government has the fiscal capacity to fund major healthcare programs, particularly during economic downturns. Another value conflict that comes into play in healthcare debates is the sanctity of property rights. For some, property rights are God-given, or at least grounded in the natural order of things. The first duty of the state is to protect them. Some believe literally that taxation is theft, and in particular taxation that results in wealth transfers. Giving to charity is commendable but must be voluntary. On the other side would be the belief that wealth is contingent. Accumulation of wealth is no doubt attributable to some extent to personal merit, but is also dependent on random distributions of inherited wealth and skills and access to education and opportunity. Much of it has to do with social and political institutions that maintain, protect, and concentrate wealth. Many believe that access to health care is fundamental to having the opportunity to be a productive citizen and is more important than maintaining the existing order of wealth distribution entirely. Equality of health is not possible, and equal access to health care is a goal that no country has achieved. But access to a basic level of health care is a goal that virtually every developed nation, but ours, has generally achieved. A transfer of wealth to increase access to health is justifiable, therefore, as a property goal, is the argument. These are then some of the values that are at stake in debates over health care reform. How then can Republicans and Democrats holding these different values, or conservatives and liberals, work together? Since we're talking about values, simple compromise is difficult. On particular issues, compromise may be possible, but it is problematic, and indeed it may be wrong, to compromise on values themselves. There is some hope, however, that Republicans and Democrats may be willing to work together on some issues, and I was just talking to David about the Problem Solvers Caucus, which is trying to do this. First, on many healthcare issues, there is broad consensus across most of the ideological spectrum. Everyone is against disease. When President Trump tried to cut funding for the National Institutes of Health, he faced determined opposition from both parties. Both parties believe that we need an FDA and a CDC, although they may differ on the funding levels for those organizations and how regulatory they should be. Virtually everyone is in favor of value-based payments for healthcare services, although they may disagree on what that means. Everyone is opposed to fraud and abuse. A surprising number of pieces of health legislation pass with the overwhelming support of both houses of Congress. In fact, I'm always impressed when I start looking at Congress.gov how much legislation passes almost unanimously. We never hear about it. Second, on a number of issues, ethical principles may be compatible with a range of options, and stakeholder interest is a powerful motivator. Congressional support for the CHIP program, or Medicaid for the disabled and the elderly, or for that matter, the Medicare program, crosses party lines. No matter how you feel about social programs, it's hard to run against children and old people. And of course, there's always the willingness to make an exception for the worthy poor, however we define that. The Affordable Care Act really touched the live wire of political and ethical debates. It attempted to extend public support to low and moderate income people of working age who were not obviously part of the traditional worthy poor. It also extended government regulation to health insurance, and in specifically federal government regulation, and therefore it came into conflict with a range of conservative values. The ACA did try to do this using conservative approaches. It attempted to cover moderate income consumers using organized markets for private health plans, and in fact, the ACA itself attempted to devolve most regulatory authority to the states, but due to political opposition in many states and the need for increased federal control to make the program work, it ended up being much less state and market-based than was originally envisioned. And it has ended up being a casus belli for conservatives. These issues have been the focus of repeal efforts all summer, which in fact only touched 3 of the 10 titles of the Affordable Care Act. Most of the Affordable Care Act would have been left in place by all of the proposals that were considered this summer. Republican repeal efforts focused on cutting back on the ACA reforms, but would have left, as I said, many of them in place. Throughout the summer, most Republicans asserted that they wanted to continue covering pre-existing conditions. This represents, I believe, a move towards a consensus of where the law should be, if not a consensus on values. Democrats also, I believe, have moved. Indeed, the ACA itself was a huge step away from the Medicare for All programs that characterized proposals from the Democrats since the 1950s. Of course, the Sanders wing of the Democratic Party is moving back in that direction, but Senator Sanders has also been one of the most vigorous and effective defenders of the ACA as it currently exists. I don't think we will ever wake up and find that Republicans and Democrats actually share the same values and beliefs about the government's role in our healthcare system. That's what defines both parties in part. In particular, the conservative and libertarian end of the Republican Party and the socialist end of the Democratic Party have radically different visions of the ideal healthcare system that are fundamentally incompatible. But I do think that the ACA has maybe moved public opinion on healthcare issues towards a greater acceptance of a right to healthcare and a greater acceptance of the legitimate role of government in implementing that right. At the same time, the public accepts a legitimate role for cost sharing and for personal responsibility in health. Few politicians can afford to completely ignore public opinion. I also think that disagreements on values does not necessarily preclude working together even on value-laden issues. Particularly now, we seem to have reached a stalemate on ACA repeal. There is an incentive for moderates in both parties to work together on practical matters. Senators Alexander and Murray have for a month now been trying to come up with a compromise to fund the cost-sharing reductions that insurers have to provide under the ACA. And the last I heard, that attempt is not totally dead. Senators Portman and Warner filed a bill last week providing for much-needed reforms to employer reporting on health coverage, which is a real mess. Sometimes it might be possible to push for solutions that work, even if they are not ideologically pure. In the end, everyone is opposed to unnecessary human suffering. Perhaps this is a transcending value to which we can all appeal. But I doubt we are going to wake up anytime soon and find Democrats and Republicans agree on everything in health policy. The most we can hope for, I think, is that they are willing to look for ways to work together to make our system work better for all Americans, even if these approaches are not fully compatible with their beliefs. Thank you. Happy to answer questions or have discussion.